our next topic, and it's Demystifying Psychiatry. And I'm going to call on Faven Araya, who directs our community engagement and research program, to lead us through that and facilitate this discussion. And she'll introduce all the players and everyone that's going to be a part of this. But it's going to be a stimulating discussion. We look forward to that. So at this time, Faven Araya.
Marilyn encouraged that if you want to stand up and take a quick stretch, you can. I am trying to wrap my head around where we're at right now because my mind is blown from Dr. August's presentation. I don't feel like it's often that we talk about mental health from the historical context, and we talk about it from that lens, so like I'm a little disoriented. But we are going to transition the conversation into thinking about what mental health looks like in practice. And to do that, I'm going to welcome a wonderful guest of ours, Dr. Cassandra Raphael, who is a double board certified physician in adult and child adolescent psychiatry. She's a native New Yorker and proud Haitian American. That's 2 today. Dr. Raphael completed a master's in public health here at SUNY Downstate shortly after she started teaching and developing curriculum with the Health Science Academy at the Arthur Ashe Institute for Urban Health, so welcome back. Dr. Raphael completed her adult psychiatry residency and child psychiatry fellowship at SUNY Downstate with the goal of improving physical and mental wellness in the Caribbean American communities. She currently works at the Office of Mental Health, New York City Children's Center Brooklyn Day Treatment Program. There, Dr. Raphael treats patients and represents New York City's multicultural and multilingual youth with culturally sensitive and holistic psychiatric care. She is an expert consultant on mental health and parenting for various media outlets. Previous collaborators include JED Foundation, the Writers for Parent Magazine, Essence Magazine, and Forbes, among others. She has also been featured on Hot 97's Nessa's podcast. She also can be heard co-hosting the Trauma Code Radio with her husband, Dr. Simon Fitzgerald. To sustain her mental health, Dr. Raphael enjoys spending time with her 2 young children, reading especially banned books, exploring arts that highlight cultures of the African diaspora, and lastly, but very importantly, she works to improve her tennis game. Welcome, Dr. Raphael.
Thank you, Faven.
All right, so we're going to have a nice conversation, or try to have a dialogue around psychiatry. I think, as Dr. August highlighted, that a lot of what mental health is centered around is this misconceived notion of what it should be. And I think a lot of it is rooted in the historical context of oppression. And so because of that, the field of psychiatry is oftentimes misconstrued. And so I think we want to start the conversation by thinking about, let's define psychiatry to understand how this can serve as a resource to our community. And so let's start the conversation with, when people hear the word psychiatry, they often imagine different stereotypes. How would you describe what psychiatry actually is and isn't?
Excellent first question. I guess as we engage in this conversation, I also just want to say thank you all for being here, for taking the time to want to learn. I'm eager to, be back and to have this conversation and enlighten as many folks as I can. And I invite your curiosity and your questions. So psychiatry is a medical specialty in which we look to understand and diagnose and treat disorders of the emotions, the mind, the thoughts, behaviors, and development. In our assessments, we follow the biopsychosocial model, and that means that we consider biological aspects, psychological aspects, and social aspects that all influence mental health and how we show up in the world. An example of a biological aspect would be maybe a developmental disorder, or how genetics interplays with how we present. Psychological factors include something like trauma. Social factors include how connected we are, what community supports we have access to, and all of these things put together influence, again, how we show up in the world. So that's, chiefly what we do in psychiatry. We have a few different modalities of treatment. I know that the common kind of misconception is that psychiatry is for medication, and that is all we are for, and there are avenues to get plenty other resources. But if you need meds, you go to a psychiatrist. When in fact, oftentimes we don't begin treatment with medications. We try behavioral interventions first. We want to understand the various factors that contribute to how somebody is presenting. And so there's an amount of talk therapy. We help to guide behavioral modifications as well. We do use medication, but it is a tool only if necessary. And I'd say that medication is definitely not the first place to start in many cases, specifically because, like I said, it's a tool that might help somebody who needs it or who might benefit from it get into the proper headspace to do the other work that I mentioned, which is the talk therapy and the behavioral modifications. So that's essentially what psychiatry is. It's also an evidence-based, ethics-based, and individualized practice in a way. We have to be very mindful of culture, context, individual nuances, and how those things impact the outcome that we'd like for our patients and what it is that the patient is prioritizing for themselves.
Thank you. My next thought is thinking about how do you know when psychiatric care is needed, right? If I'm someone who's dealing with stress or anxiety, is my first thought I need psychiatric services, or are there different pathways to seeking services, and how does someone end up receiving psychiatric services?
Well, I think, I know we're going to talk about a lot of different modalities as we continue the conversation, but I would say that an appropriate time to pursue psychiatric care specifically is when symptoms are persistent, developmentally kind of inappropriate, like if you have excessive aggression or excessive isolation, for example, there might be more needed, especially if you have these things persistently. You might need more than, community support, for example. And especially if the symptoms interfere with daily functioning and your ability to show up in the world as, at least as your best self. So if you're, unable to go to school if you're a kid, when that's essentially the work of children is to go to school in an ideal world, right? So if you can't do those things, if an adult is not able to kind of, get up and operate and be productive and connect with others, these are all signs that there may be more going on than, than standard interventions might resolve on their own.
Right. And I think a lot of people probably experience waves of that, and trying to figure out when is an appropriate time is always, I think, the point that is the hardest to determine. But once that conclusion is made, I think I need services. I've been told that I need psychiatric services. This is a resource that's available, but it's oftentimes not utilized. And so what do you feel like are the barriers that get in the way of people utilizing these services?
In Dr. Auguste's talk and in, previous speakers have also addressed the same thing. We internally or within our communities, there's obviously the element of stigma, and the stigma comes from kind of carrying the misconceptions, which I don't know if I mentioned any misconceptions as yet about psychiatric care. No. Perhaps not. Right. So stigma is kind of perpetuated by carrying these misconceptions about what psychiatry is, and I think some of those misconceptions in underserved communities include perceiving that if you need to talk to a psychiatrist, that something must be very, very wrong, or that it's a dangerous situation. The perception that psychiatrists will only give medications, very important in our community is the perception that psychiatry is necessary for folks who are weak, that psychiatry is, quote, not for people like us, right? That psychiatry is kind of culturally exclusive. So that's another common misconception. The confidentiality, feeling like, if you talk about the problems, if you name the thing, if you are too open about your problems, you're just going to perpetuate them and not actually just take the first step into changing a situation that doesn't suit you. So those kinds of misconceptions about psychiatry and psychiatric care are contributing to our own biases about what we think psychiatric care is as a community. And that's, internal to us. I think it's also very important to discuss things that are external to us. So structural or systemic illnesses or biases, for example, that get in the way of pursuing proper psychiatric care. So when I say those things, I'm talking about the reimbursement rates, for example, for mental health care in general, either through private insurance or through Medicaid. If the reimbursement rates are not great, it's hard for people to access care, right? Long wait lists because there are not very many psychiatrists, and even fewer who are folks of color. Like maybe 2% of psychiatrists in this moment are Black, maybe 10% are non-white, right? And about 60+% are male when there's a large amount of female patients who might be trying to navigate some kind of trauma or overcome some kind of traumatic symptoms that they'd perhaps feel more comfortable speaking to somebody who looks more like them, right? So those, and how accessible is medical education? I guess that's another thing, right? So when we're talking about systemic or structural matters, if medical education is not that easily accessible, or professional education is not that easily accessible, or it comes with a significant debt burden, it makes it that much harder for us to engage and follow the course and delay the gratification of a paycheck, right? So we kind of have to, I guess many of us feel compelled to start working either right away and not be able to pursue the information to do this job. And all of those things are structural matters. So we need to make education more accessible. We need to increase the number of people and the diversity of the workforce in mental health care. We need to have our workplaces make the time and access to care easier. It would be great if there would be better reimbursement rates for the services that might be needed in the community. So those are some of the barriers and perhaps some of the responses to those barriers.
Yeah, thank you. And I appreciate you naming the structural issues that get in the way. And I want to think about the present moment that we're in, and I feel like the structural issues are amplified right now with the attack on public health, the attack on immigrants. You feel that mental health is being impacted, like people are suffering, people are going through a whole lot of challenging moments and times.
Definitely.
And the systems that are supposed to be responsive to them and are supposed to be open to them are not. There are places where folks could be detained, for example. And so can you talk about how the present moment serves as a barrier to access to services and what that looks like right now when the need feels immense?
Two things come to mind pretty immediately when we think about, so in answer to your question, so two, I guess what current events or hot topics right now come to mind immediately, and one of them is cutting Medicaid, right? So about 30% of non-elderly patients who receive mental health care or psychiatric care are covered by Medicaid, right? The reimbursement rate's already not great. The wait lists are already long. And so, to remove the access for those folks is going to kind of flood the system. It's going to flood a system that's already overburdened, right? And or it's going to further marginalize folks who would hesitate to come for care. Now there's no reason, you know, and then what happens if people are not able to show up in the world and you know, engage in their role functioning is fewer goals pursued, and thus, you know, the unhoused population may increase. Food security will decrease as well. And that actually brings me to the second thing, is the SNAP benefits, right? So if we cut Medicaid and then we cut access to food, and food security is not a sure thing, we're not only impacting the people who actually get the service, but also their families, the people who depend on them. And so the mental health of families as a unit, you know, can decline if we remove access to certain resources that keep us well. And I think that we don't always name or pay particular attention to the things that keep us mentally well, but food security is one of them, you know? A reliable paycheck is one of them. And it's not directly linked, but if that link isn't explicitly stated or obvious, I think if you consider what life would be like without some of those things, then it becomes much easier to kind of say, okay, I could see why just losing access to my food benefits, just losing access to my healthcare services, my community supports, it's going to be very clearly a direct relationship to how well I am mentally.
Right, and I think that makes me think about health as a human right? Like, we're having a conversation around not having access to food, access to healthcare, access to a safe environment. These are all basic human needs, and yet we are talking about systems that are taking those basic rights away. And so this is a part of a history of mistrust. This is why people don't want to connect with the healthcare system or don't believe in these institutions and their responsibility for taking care of the community. And so what role do you play as a psychiatrist in acknowledging the history of mistrust, the fact that the mistrust is being perpetuated by current policies and practices, and how do you bridge that gap?
I think you touch upon a few different things in that question. You do mention the medical mistrust, and I want to be very clear in distinguishing that from stigma, right? I talked about stigma and what the misconceptions are about what psychiatric care looks like, but then I also I'd be remiss to not acknowledge the history of medicine that contributes to a rational amount of apprehension from our community when we're talking about, you know, engaging in mental health care or medical care at all. Specifically, let's say the Tuskegee study or forced sterilizations, the history of Henrietta Lacks and kind of exploitation of certain populations. We have reason to be apprehensive. Hold on, I missed a part, I think, of your question.
It's just thinking about, so you're acknowledging the history of it in the
Yes.
medical system. So what role do you as a psychiatrist play in, especially a Black psychiatrist, in bridging that gap and ensuring that the historical context and the present moment are acknowledged, but also addressed in the way that you provide care?
I think that medicine, so I guess here's where I was going. I think that medicine still has a long way to go in leveling the playing field and getting equity in care, right? So as a Black psychiatrist specifically, having gone to medical school and residency in, you know, in a world where Western medicine is largely created or dominated by one culture, how do you say, the expression, the master's tools will never dismantle the master's shed? Mm-hmm. Yes. If I want to know the nuances that make working in certain populations different, or the cultural differences that will arise from patient to patient, and removing the explanation burden that somebody has to, you know, come in and say, oh, you know, my grandma said this to me, and then they have to explain all of what that means before we can really decide, you know, how that can contribute to the conversation we're having, right? So removing that explanation burden. those are the things that we have to seek to know. I think as physicians, there's a lot of information there's a ton of information in medical school, but still, I think if you want to do it from a culturally influenced, respectful perspective, it takes more work outside of the textbooks sometimes. It takes conversations, it takes reading books by Frantz Fanon and several of the other folks that Dr. Auguste mentioned, to understand the history and decide what is an approach that will make the patient feel centered in all of our interactions as, patient and doctor.
So I just got the notice that we're out of time, which went by really fast. But I want to ask one question before we open it up to the audience. You are bringing up the concept of taking into consideration someone's identity, their culture, their backgrounds. And so as a Haitian American, you carry those things, and there's a level of consciousness that you bring to the table, I hope, I assume.
Me too, I hope so too.
As you provide care. And so what does that look like, and how can others who are either in the field, exploring the field, or exploring, or in a position where they are serving the community, how do you take culture, identity, religious beliefs, how do you take that and use it as a tool, a powerful tool, to empower people and to get them the type of support that they need?
You mentioned a little bit earlier that, not directly like so, but basically implied, right? That we're living in a time when people are being persecuted for who they are rather than what they've done, right? So it's important to create connectedness, create places of psychological safety, create places, even environments where people can be wrong, but called in, and to feel like not only do they benefit from having a community for their own interests, but also they feel like contributing to that community is productive for them as well, right? It gives them an identity, it gives them a place. So the kind of connectedness and in person, when possible, would be one of the things that I think are very important in terms of creating a safe place and removing some of the barriers to mental health care in our community. I'd say also normalizing and even initiating these conversations so that somebody doesn't feel, pardon me, so that somebody doesn't feel like having these issues is a problem in itself. Everybody has something that they're trying to navigate, trying to figure out, something that they feel might be obstructing them, in whatever their journey is, whatever their goals are. If we are able to name those things and identify the point where community support can help, and then mental health care can kind of support even more, just add another layer to the services and access, then that's important. So initiating these conversations, normalizing these conversations, just like what the symposium is intended to do. Those who are allies, have a huge responsibility to this, continue to advocate for mental health care and services to be accessible in the school settings, in community-based organizations, which I know you can name several that might offer some mental health care services, or at least connect to mental health care services. I guess in times like now, when it feels as though so much that influences our mood and thoughts and behaviors are not within our immediate sphere of influence or control, the role of psychiatry, I would say, is to help folks find peace and power. And I don't want to conflate peace and acceptance, right? There's the serenity prayer, the courage to accept, giving the serenity, right? To accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference, right? So in peace, we find the power that we need to change the things that do not serve us, that do not serve our communities. And I think that that's the role of mental health care in times like now, finding our peace, finding our power, and building connectedness.
I love that. Thank you.
Thank you.
And so, as you highlighted, as a way of initiating the conversations, we invite any of you all to ask the psychiatrist any questions that you may have about the field, about the work, about the way that you can utilize the services, about the experience, about any misconceptions that you may have. So we have the mics up front, and then we also can bring a mic to your seat.
Hi, thank you so much for this whole morning. I think it's just been so enlightening. I'm Natalie Rubio Torrio. I run an agency called Voces Latinas in Jackson Heights, Queens. One of our therapists is here with us. And one of the things that we have for years tried to think about is a community mental health model for us, for our community. We work with predominantly immigrant and migrant Latinos, and especially after these past 3 years, as a result of the influx of migrants, we're seeing the even more need for mental health services. And I'm feeling like we are on the right path after hearing from you and Dr. August. Because what we don't ask enough is what has been working for you in terms of healing practices. And we're trained this way to kind of stay away from religion, spirituality, and I think just focus on like the Western medical model. And I guess it's a comment, but also a question. We know this doesn't work for all of our communities. We know we need to think out of the box. We know we need to ask people what helps and then incorporate that into their service plan. And that's what we're trying to build. But there's not, well, I will be calling upon you all, but there aren't many people or trainings or institutes that we could call upon to ask for guidance and ask for help, because we can be challenged when it comes time to how we're being trained. Maybe as example, mandated reporters, right. Or because I've been in those situations where, especially we have students, we have MSW students, and it could be very challenging when they come from the theoretical educational place to the practice with this particular culture. And so I'm just wondering how we navigate, maybe some resources where we could tap into, just to help us continue to build, because it is something that we feel and we need to offer our community to really heal. And we've also just started doing healing circles, and we're finding the power in healing circles for our community. But we also need a lot more guidance, resources, and just support.
Thank you for that. It seems that you're doing marvelous and very important work in the community. I'm tempted to get on my soapbox. Geez. But I think that there's, when we go from medical school to practice, I wish that the history of medicine in this country and in other countries and the value of more indigenous practices was more highlighted. I think it should be in medical education, because I think the easiest thing to do is to, somebody's child says, oh, you have high blood pressure, you need to go to the doctor. And they make the appointment, they come. But unless you're willing to hear them, talk about the tea that they think is helpful, and they're not going to take the propranolol or whatever other thing that you have in mind. So we have to listen, and we have to put aside some of the biases that, as clinicians, that we come into these conversations with, and make space for the people who are coming to see us for our service. So I guess I'm proposing a systemic, which of course will take a longer time. A systemic solution is to begin this education as early as possible in the medical career. It can't happen like one and then the other. It has to all happen at the same time, Resources for, I guess, improving cultural competence, yeah? Well, I will say this. There's a lot of evidence to support that concordance between patients and providers optimizes outcomes, right? Typically in psychiatric practice, in mental health care, at least in this state, you're entitled to interpretation services. It's, you know, almost even better if you can have an in-person bilingual interpreter or a bilingual provider, but of course that comes with its own barriers, right? Just getting the access to the education. I know that in terms of the resources, Faven, you might be very well versed on what community supports exist that might also be helpful.
Yeah, I mean, I can give you specific resources and we can talk afterwards, but I think one of the things that I'm taking away from this conversation is that the healing circles are done in practice with the community, but I also think that that needs to be done with the support systems, the people who are facilitating and providing access. And so how do we connect with one another? Because it seems like there's a very small percentage of psychiatrists and psychologists, right, and that probably is reflected in the other parts of the mental health field. But how do we come together and align our resources? How do we amplify our efforts to be able to serve our community? And I think that there's power in that. And so, yes, there are specific things that I can share with you after, but I think it's thinking about how do we do this in a more practical, sustainable, consistent way so that we can continue serving our community.
And also, I mean, I alluded to this earlier, but also in a preventive way, right?
Yeah.
We're not responding to a crisis. We're talking about these things up front. We're normalizing these conversations, you know, in broad form, so that if somebody is struggling, they know that they're not alone, and they know that this is not something that's isolated and insurmountable. The support exists, and they know that because we have these conversations before a crisis even occurs.
Yeah.
Right.
Yeah, it's critical. So we have time for one more question. I saw one in the back. And then there's plenty of time during lunch. We have an hour to sit and connect and to share.
Come say hi. Yeah.
Hi. Oh, can you hear me? Okay. Hi. So my name is Elizabeth Osborne. I work for JASA. I'm a resident service coordinator. So my question is, well, first, let me be real brief. I actually had an inpatient psychiatric visit in October, and I say that because I live in the Bronx, but I didn't even feel comfortable going to Bronx hospitals. And many people that I speak to, I've also worked with people that have Medicaid, and oftentimes they don't like Bronx hospitals either. People say that they were traumatized or that they got discharged early when they shouldn't have been. I've spoken to other people that didn't know where to get therapy and all. I like to set my friends up with various therapists and have resources. And I keep hearing that we have to advocate, but how does someone like me who doesn't yet have their master's advocate for more access to mental health care in the Bronx or better quality mental health care in the Bronx?
It's a brilliant question. And I just also want to say that your transparency and vulnerability is very powerful. One of the resources that I find very helpful are peer support programs. So people who have a certain lived experience learn how to engage others who might be having a similar experience, but whether or not they're insightful about, you know, what might be necessary is a different thing, right? So I think the peer specialists are a wonderful and very helpful and supportive and collaborative group. So I would definitely start there. I would, like I said, your transparency is so helpful here too. Continue to have those conversations, continue to ask these questions. Continue to ask questions about what is available and why certain other things are not, because it's not happenstance. A lot of these things are very carefully decided without our representation in the room, frankly. Being sure to gain access to the, and when I'm talking about these conversations, making sure that the access to public funds for community health clinics, community-based organizations that are doing the work of connecting folks to care, that continues to exist. Continue to advocate for yourself. I think yesterday I had a young patient, he's like 16, and he's like, what did I do? And I said, well, you did something, but, and he was shaking in his boots till we got to the office, and I said, you advocated for yourself. You said, why did the medication look different than last time? And this is important. You are coming for a service when you come to see psychiatry, when you come to mental health care. You don't have to necessarily accept whatever is put forth. In an ideal scenario, you have community or family support. You're not living in isolation, where even if you may not be able to speak, as fluently as you might want to about what might be helpful to you, people who know you can. And this is why the community aspect and the connectedness in mental health is paramount. I rarely do my job without speaking to either a grown-up of a kid or a sibling, somebody else who can help me understand what is this person's values, because maybe in this moment they might be more compromised than how they'd like to represent themselves. But the value of those interactions is very, very helpful if the patient is not sure why they're with me, you know what I'm saying? So continue to advocate for yourself, advocate for your peers, and I would encourage everybody else here to do the same thing. Keep talking about it, keep asking the questions. And keep, if you know something is accessible in Manhattan and not in the Bronx, find out what it is and how they got it. And make sure that you can, when there are town halls and things, you say, look, this is something that I think we need here. The more we talk about it, the more we get. What is it? Squeaky wheels? What is it? What is it?
I don't know the saying, but you're talking about being a squeaky wheel.
Exactly. Or closed mouths don't get fed. There, same thing. Yeah. The more we talk about these things, the more that we let people know that we know, the more they realize they cannot hide resources.
And also just add, don't let people think, or don't let the idea that you have to have a degree in order to be positioned to advocate. Think about the space that you occupy and what role you can play in elevating your voice and your concerns. And when you get that master's degree, it will just help amplify that. But it's not necessary.
I'm gonna get it anyways. Yeah, I'm getting it anyway.
Well,
yeah,
yes,
do
but
that.
I'm just saying.
Do that, yes. Get that degree.
So
But
thank you for your question. Thank you for your transparency. We can continue this dialogue, but for the moment, I want to say thank you, Dr. Raphael, for coming back, for continuing to be a resource and to impart your wisdom.
Thank you very much, Fabian, for having me, and to the Arthur Ashe Institute, who has been so influential in my journey to medicine, to psychiatry, to teaching, and everything else. It's been an absolutely wonderful experience. It's an honor to be here with you all. So thank you.
Thank you.